واضحة؟
دقيقة واحدة يا سيدي. نعم سيدي صحيح، واضحة سيدي الأمور. بس تحب تحط F5 عشان تبلش
أي
سلايد.
بلش.
بس سيدي أبو عزيز تعمل أنا ميوت من عندك إذا ممكن. دكتور محمد.
عملنا.
الله يعطيك.
لا
تفضل سيدي.
مساء الخير شباب، يعطيكم العافية. أنا الدكتور محمد العلوان، أنا أخصائي أول جراحة عظام وأورام. إن شاء الله اليوم راح نحكي عن approach to musculoskeletal oncology patients. هسا شباب اللي بيحب يسأل سؤال يفتح المايك تاعه ويسأل، ما عندي مشكلة. This is an overview of orthopedic oncology specialty. It's a unique subspecialty within orthopedic, and we see all patients of all ages. We deal with the problems involving the upper extremity, lower extremity, pelvis, and sometimes spine. We see variety of tumors, including benign, malignant, primary bone tumor, benign and malignant soft tissue tumors, and metastatic tumors. We also see a variety of metabolic bone abnormalities, skeletal dysplasia, genetic disorders. The oncology service operates throughout the body, including upper extremity, pelvis, lower extremity. We rarely use a standard approach for our operations. We use variety of methods for bony reconstruction, including polymethyl methyl acrylate, bone cement, allografts, autografts, and oncology prosthesis. We use standard plates and rods, as well as a special design plate and rod for any areas of the body. We can use a variety of techniques for soft tissue reconstruction, including complex closures, negative pressure wound vacs, split thickness skin grafts, and rotation flaps. Some of our surgery will require other surgical teams, including vascular for vascular reconstruction or large vascular injuries, microvascular for free flap. We occasionally do combined cases with general surgery and thoracic surgery service as well. هسه راح نحكي عن approach to musculoskeletal oncology. My lecture will start by introduction, etiology of musculoskeletal tumor, epidemiology, risk factors, evaluation of musculoskeletal tumors, imaging studies, lab studies, and the biopsy and staging system. In introduction, tumors of musculoskeletal system are an extremely heterogeneous group of neoplasms. Consist of over 200 benign types and 90 malignant types of neoplasms. The incidence of benign to malignant disease is 200 to 1. The musculoskeletal system tumor arises from embryonic mesoderm. Soft tissue sarcoma are rare. They account for less than 1% of all cases of cancers, all of the cancers cases. But there are dozens of different types, and they can happen in children and adults. About 13,000 people are diagnosed with one of these cancers every year. The etiology of musculoskeletal tumors, it's a complex, multiple steps process by healthy tissue progressively to transform from normal phenotype into abnormal colony of proliferating cells. This is what happened in all tumor. There's genetic abnormality in oncogenes, tumor suppressor genes, and other genes that directly and indirectly control proliferation. So this leads us to know about the cell cycle. The cell cycle has 4 phases. It's in the mature state, it's a G0. But in the cell cycle, there's 4 phases. G1, gap 1, majority of cell growth take place in it. And the S phase, it's DNA synthesis. G2, it's a gap 2. Then M phase, the mitosis, separation, and cell division occur. This paragraph shows the cell cycle. As you see, the G1 is larger than G2 because all the growth and happens in G1. The hallmark of neoplastic disease is factor affects the exit of the cell from G0 with entrance into G1. There's inheritable genetics, environmental factors. Environmental factors we can know from as oncogenic viruses, radiation, chemical carcinogens. This is the affecting this G0 to G1, and there is affecting the numerous regulatory proteins and checkpoints, and the proteins are encoded by two basic genes, the oncogenes and the tumor suppressor genes. Epidemiology. The American Cancer Society estimates for cancer of the bone and joint for 2021 this is a new study, and this is an estimation for 2021 السنة اللي احنا فيها. About 3,610 new cases will be diagnosed in musculoskeletal oncology. About 2,060 deaths from these cancers are expected. Primary cancers of bones account for less than 0.2% of all cancers. In adults, over 40% of the primary bone cancer are chondrosarcomas. This is followed by osteosarcomas, then chordomas, Ewing tumors, and malignant fibrous histiocytoma, or called fibrosarcomas, 4%. The remainder of cases are several rare types of bone cancers. In children and teenagers, osteosarcoma and Ewing tumors are much more common than chondrosarcoma. Chondrosarcoma develop most often in adults with an average age at diagnosis is 51. Less than 5% of cases occur in patients younger than 20. Chordoma are also common in adults. Less than 5% of cases occur in patients younger than 20. Both osteosarcoma and Ewing tumors occur most often in children and teenagers. So the vast majority of primary bone tumors are benign, and since many are non-symptomatic, they remain undetected or are detected only incidentally at radiologic examination for other reasons. The true incidence of benign bone tumor has therefore been difficult to determine. This is a percentage for primary bone tumor frequency. Like osteosarcoma, it's about 35, Ewing sarcoma 16%, malignant fibrous histiocytoma 5.7%, malignant angiosarcomas 1.4%. So the classification of primary benign bone tumor peak age and most common site distribution. So it's important to know the age for the patient. So it's have age group for every diagnosis, mostly, of course. The histologic classification of bone tumors is based on cytologic finding in a particular cell type, such as osteocyte, osteoblast, chondrocyte, chondroblast, osteoclast, architecture, and type of matrix produced by the tumor. So this table shows the histological type, the origin cartilage. So it's a cartilaginous tumor, like this is a benign tumors, osteochondromas, enchondroma, periosteal chondromas, chondroblastoma, chondromyxoid, bromas, and all of them there have a peak age from 10 to 30, like osteochondromas. Most common site distal femur, proximal tibia, proximal humerus, rarely from a flat bone. مع انه بنشوفها بالسكابula. Enchondroma usually بالhand, feet, longitubular bone, and osteogenic origin tumors like of course benign tumors, osteodysteoma, osteoblastoma, and age is 5 to 25, osteodysteoma, osteoblastoma 10 to 40, and there's common places to find them. Fibrogenic tumors, dysmoplastic fibromas, you can find it in femur, pelvis, mandible. Fibrohistocytic tumors, benign fibrohistocytoma, you can find it in pelvic and femur. Giant cell tumor, it's 20 to 40 or 20 to 45. Distal femur and proximal tibia, distal radius, and the sacrum. There's some of the most common places. Vascular tumors, hemangiomas, lymphangiomas, glomus tumor. Glomus tumor, we usually find it in the distal phalanx of the hand. Epithelioid hemangioendotheliomas. This is benign, but لسه الحكي للstudies عليها, it's not truly benign and not truly a malignant. Soft tissue type tumors like lipoma, schwannomas, leiomyomas. But the classification of primary malignant polytumor and the peak age and the most common sites, we can find it in this table. Histological chondrosarcoma, it's from the chondroid tissue, so chondrosarcoma. There's a primary, secondary, and there's a clear cell chondrosarcoma, mesenchymal chondrosarcoma. The osteogenic distribution is tumors like osteosarcoma. There's a lot of types of osteosarcoma: conventional osteosarcoma, telangiectatic osteosarcoma, osteosarcomas, paraosteal, periosteal, high-grade surface, and you can see it's usually from 10 to 30 peak of age presentation, and usually it's around the knee, distal femur, proximal tibia. And there's a secondary osteosarcoma from Paget-associated post-radiation, other conditions. The secondary, you can see it's the peak of the age is 50 to 90. So in the elderly, you can find it. Ewing sarcomas 5 to 30, usually pelvis, bones, lower and upper extremities. So it's the same like osteosarcoma. Fibrosarcoma 40 to 70. Malignant giant cell tumor, usually 20 to 60. It's around the knee region. It's very rare, but we saw it in our cases. There's the vascular origin like angiosarcomas, and there's adenomas. It's a rare tumor. Usually, it is characteristic in the tibia and rarely in the ulna radius. Okay. So, what's the risk factors to have a musculoskeletal tumor? It's not clear what causes bone cancer, but doctors have found certain factors are associated with an increased risk, including اللي حكيناهم قبل: inherited genetic syndromes, certain rare genetic syndrome passed through families, increase the risk of bone cancer, including Lee-Fromin syndrome and hereditary retinoblastoma. Chemical exposures, radiation therapy, exposure to large doses of radiation, such as those given during radiation therapy for cancer, increases the risk of bone cancer in the future. Weakened immune system. People with HIV sometimes develop Kaposi sarcoma. It's a soft tissue type of soft tissue sarcomas that developed from the cells that line blood vessels or lymph vessels. So, evaluation of a musculoskeletal tumor patient. We must start by history and physical examination. imaging studies, lab studies, and finally we go for biopsy. History. What we emphasize on history, what we found in history. The patient age. It's important to know the patient age and the gender. As we saw before, there's a peak age distribution for every diagnosis. Duration of complaint, rate of growth, pain, history of trauma, family history, systemic symptoms. Patient age, certain tumors are relatively specific to particular age groups. This is simple as that. This slide shows the age groups. This is أوضح. Simple about cyst, ewing sarcoma, chondroblastoma, then ossifying fibromas, myelomas, metastasis. You can see the age group. Duration of complaint. Benign lesions generally have been present for an extended period, years, while malignant tumors usually have been noticed for only weeks to months. هذا الحكي احنا بنشوفوش مع بعض يعني عشان مرة بيجوا late stages as a denial stage انه بتروح لحالها. Rate of growth. Rapidly growing mass, as in weeks to months, is more likely to be malignant. But the growth may be difficult to assess by the patient if it's deep-seated. There's a phenomena called the iceberg phenomena, the tip of the iceberg phenomena. So what is appear in the surface is not like that in the deep. The pain, benign process, usually asymptomatic, or may cause secondary symptoms like compression, to do compression, the nearby structures. Most common presentation malignant process is musculoskeletal pain. It's usually asymptomatic also, but if there's a symptom, it's pain. And how the characteristic of this pain? Deep-seated, dull in nature, intermittent, related for activity, increase at night, progress in intensity, not relieved by NSAIDs. أتوقع هذول واضحات. History of a trauma شو بتفيدنا؟ شو أنواع التروما؟ الأنواع التروما is penetrating or blunt trauma. If it penetrates and persists of penetrating trauma بصير تفكر بأوستوميلايتس rather than tumors. Blunt trauma بصير تفكر healing fracture أو إنه there's calcification, heterotopic ossification in the muscle. Family history, as we said, there's some family history of some syndromes give you a risk for sarcomas. Systemic symptoms in benign tumor, there is no significant findings on the review system. Fever, chills, night sweats, malaise, change in appetite, weight loss should be alert the physician that an infectious or neoplastic process may be involved. So this is history, and it's very important to us to know some history for a patient. And we go for physical examination. As any system, we go physical examination for a tumor is inspection, palpation, and specific system examination. So mass examination, أتوقع الكل بيعرفه. It's very simple. By inspection, you must see the skin color, skin changes, location, size, palpation, tenderness, temperature, consistency, pulsation, joint range of motion, neurovascular exam, lymph node exam. This is a mass examination. Specific system examination. احنا بيهمنا some systems to examine. They are the thyroid, breast, chest, liver, kidney, and prostate or rectal tumors. Because these are, if there's a malignant process in these systems, it's mostly, most commonly metastasized to bone. Now we go for the most important for this lecture is the imaging study. يعني اتوقع انه بعد هاي المحاضره ان شاء الله ما بنشوف تحويل من الطوارئ نفس اليوم وبيجينا مريض مقطوع كلبه على العياده بس عشان انه واقع وتصور ولقوا عنده سيست. So imaging studies. We know the X-ray, ultrasound, CT scan, MRI, bone isotope, and PET scan. X-ray. It's the best modality for characterizing a bony lesion as benign or malignant. يعني تخيلوا قديش مهم الإكس-ray. Many lesions have characteristic appearance that allow for accurate diagnosis and provide us a roadmap for further investigation and diagnosis. According to the X-ray and the history taking and physical examination, you can give the accurate diagnosis for this lesion. By X-ray, we see which bone involved, which part of the bone is involved. Is the bone normal, open or closed physis, the matrix of the bone, cortical destruction, periosseal reaction type, pattern of destruction, geographic primitive, moth-eaten, margins, trabeculation, cortical erosion, penetration, expansion, periosseal response, continuous or interrupted. So this figure shows the X-ray manifestation for like there's a geographic bone destruction, solid periosseal reaction, primitive bone destruction, moth-eaten appearance, calcification, which part of the bone, epiphysis, metaphysis, growth plate. So type of bone destruction, there's a geographic destruction, moth-eaten, and primitive. Geographic lesion. It's a slow-growing lesion, clearly demarcated border, narrow zone of transmission. There's a sclerotic rim, not usually, sclerotic margin, less aggressive, usually benign, expectation like myeloma. You can find mets, osteomyelitis, and the benign process. This is some X-rays showing a geographic lesion. This is a geographic lesion in the distal radius, in the epiphyseal metaphyseal area. It will demarcated. You can see, you can, but there's no sclerosis in the ridge. Also, this is a proximal humerus showing the metaphyseal area. It's a well demarcated, so it is, you can draw it, geographic destruction. Types of margin around lesion give us the idea of the activity of this lesion. Type 1A, 1B, and 1C, 3 types. Thick, complete sclerotic margin, it's an active lesion. 1B, it's a thin and incomplete, it's an active lesion. 1C, it's a no sclerotic margin, aggressive lesion. Okay, so this increase the aggressiveness. 1A, 1B, and 1C. Here, well sclerosed. There's no sclerosis, but it's well defined and with ill-defined margin. So this is some X-rays. This is the distal tibia lesion, well demarcated and sclerosed in the distal tibia. So this is 1A. Forget the diagnosis. This is non-ossifying fibroma. This is distal radius and well demarcated but not sclerosed margins. And this is giant cell tumor. This is also the same. There's no sclerosed rim. And this is 1C margin. Also, this is the radius giant cell tumor. Moth-eaten bone destruction. More aggressive destruction, less well-defined margin, larger zone of transmission, multiple punched out holes in bone. You suspect pregnancy and osteomyelitis. This is moth-eaten bone destruction picture. moth-eaten يعني العث أكل البون عث زي أكل العث للخشب. So you can see it in the this X-ray. It's moth-eaten مأكول أكل. Primitive bone destruction. It's aggressive, rapid growth potential, poorly demarcation, cannot delineated where it begins and where it ends. Ewing sarcoma, osteosarcoma, osteoporosis, osteomyelitis. You can see all the, you cannot rule out osteomyelitis. تفضل. So this is
هاشم الحديد في سؤال عندك؟
لا حكيم لا.
Okay.
So this is a primitive. It's rapid growing mass tumors. The bone cannot contain it. Give us the Codman's angle, triangle, sun-pierced appearance, and eaten up the bone. You can't find the mass. Where is it? So it's a primitive. It's a very aggressive. Give us an idea. This lesion is very aggressive. Visible tumor matrix. If it's cartilage, it's calcified. If it, in the bone, it's bony. It's ossification. Most differentiated matrix from calcification due to necrotic tissue, callus or sclerotic response of non-neoplastic condition, as we show. So there's a lot of types. There's a solid, stippled, cloud, ring and arc, ivory-like, fluorescent. Calcification. قلنا calcification يعني cartilage tumors. Cartilage grows in lobular manner or ball-like manner. Calcification occur at periphery. If it is complete circumferential, it's ring. If partial, it's arc. Like in chondromas, chondrosarcoma, chondroplastomas, يعني cartilage origin. Here's the stipple. You can see the stipple calcification. This is calcified in chondromas, and this is the osteochondroma. Ossification, cloud-like, fluffy, marble-like. Osteosarcomas, osteomas, osteoblastoma, rarely calcification. So this is a bone-forming tumor. It's very aggressive. You can see it's an aggressive tumor by X-ray. The periosteal reaction is very important to see it on X-ray. Will occur whenever the periosteum is irritated. بغض النظر شو الكوز. If you have periosteum irritation, you have a periosteal reaction. This may occur due to malignant tumor, benign tumor, infection, trauma. So there's many causes. There are two types of periosteal reaction: benign or aggressive. The benign process of periosteal reaction, slow-growing tumor will cause thick, wavy, uniform, or dense periosteum, or periostitis. Since it is a low-grade chronic irritation, the periosteum has time to lay down thick new bone and remodel into a more normal-appearing corpus. While the aggressive processes, such as the malignant tumor, cause a periosteal reaction that is more acute and high-grade. The periosteum does not have time to consolidate. It appears laminated, onion skin, amorphous, sun-pierced. So what's the tumor do for the bone and what the bone do for the tumor? When periostitis is seen, the radiologist should therefore try to classify if it's benign or aggressive. This classification also has its limitation. These limitations are similar to those seen with cortical destruction, such that benign process in infection or eosinophilic granuloma may cause aggressive periostitis. However, seeing benign periosteal reaction can be very helpful because malignant lesion cannot cause benign periosseous reaction. So in this X-ray, we see the onion skin periosseous reaction, and this is seen in Ewing sarcomas. This is the sunburst pattern, and this is an aggressive. We see it in osteosarcoma. There's a thick ivory periosseous reaction. It's benign, so eosinophilic granuloma, but it may cause aggressive periosseous reaction. So it's you can see if we go to the right, it's more malignant. Our differential diagnosis. We can see the onion peel and the sunburst Goodman triangle. Okay. Orientation or axis of lesion. This is not usual. It's helpful, but if the lesion growing in long axis of bone, it's mostly benign. But if it's growing in circular orientation, you can say it's a malignant. Too many expectations to each to be useful. Exceptions, for example, Ewing sarcoma malignant lesion. So it's not that important, the orientation of facts. اجينا للمهم zone of transition. What is zone of transition? Zone of transition هي المنطقة الحدودية بالعربي. منطقة حدودية بين الليجن and البون الطبيعي. So it describes the border of the lesion with normal bone. Simple as that. It's the zone of transition. هسه ممكن تتصنف لشغلتين narrow or wide. هسه إذا كانت narrow شيء كويس ولا شيء مش كويس، ولا إذا wide هو اللي كويس. لا. Narrow, it's a most reliable plain film indicator for benign versus malignant lesion. Narrow, it is الإشي كويس. If it is so well defined that it can be drawn with a fine point pin, a benign process should be considered as the most likely possibility. While the wide, it cannot be drawn at all. An aggressive process should be considered, although not necessarily a malignant lesion. ممكن osteomyelitis. هون narrow zone of transition. نفس الحكي sclerotic rim, geographic appearance, geographic destruction of the bone, metaphyseal area, sclerotic rim, and the zone of transition. يعني مش مبين عندي انه في منطقه يعني المنطقه الحدوديه قريبه على بعض، يعني ما هي normal bone وهي السكليروتيك rim. It's narrow. So we give this diagnosis as a benign process or benign lesion. فشوف قديش مهم الاكس راي، يعني you can differentiate it's benign or malignant. بس هون هاي primitive bone destruction, ill-defined, and the zone of transition يعني هون ما يعني it's wide، ما بقدرش ارسمها احدد انه الليجن. This is an aggressive process. So there, of course there's a pathological fracture. يعني هسه الشباب اذا صاحيين يعني راح نقول لك في fracture. This is an aggressive process. So could be infection, could be tumor, malignant tumor, of course. So summary of radiological findings. يعني المحاضرة إذا بتطلع منها بس بالسمري هقول يعني بتكون الأمور كويسة يعني وتصير الأمور عليك وأسهل إن شاء الله. Cortical destruction is less helpful than periosseal in assessing whether a lesion is benign or aggressive. So periosseal reaction مهم جدا إني أعرفه، والcortical destruction بس periosseal أهم. Axis of lesion is not that helpful زي ما حكينا. Zone of transition is most reliable plain film indicator of benign versus aggressive process. Zone of transition. If a lesion is aggressive, it is not necessarily malignant. ممكن تكون osteomyelitis. So احنا شفنا في radiological finding types of bone destruction, geographic, multi-ten, primitive. tumor matrix, calcification or ossification, periosteal reaction, orientation of the axis of lesion, zone of transition. Okay, this is the X-ray. So هسه لما يجينا مريض بكون مصور رنين برا، اول ما يجيني بطلب له اكس راي، انا ما بطلب اشوف الرنين، بطلب الاكس راي. وخاصه لما نروح نتناقش مع جماعه تخصص كلينيكال راديولوجي، بيجي يقول لك وين الاكس راي؟ بنصور اكس راي ولا لا؟ This is the most important for managing and evaluating tumor patients. CT scans. CT scan provide diagnostic information of bone and soft tissue in another plane. But soft tissue مش كتير. Mostly it's for bone. We use it for smaller lesions involving the cortex of the bone. Mainstay for safe and accurate biopsy procedures. CT for CT guided biopsy. For staging, also we use CT scan, and for angiogram, CT angio. MRI, imaging procedure of choice for determining the extent of a lesion, both in the skeleton and soft tissue. T1 weighted images best for looking for extent of marrow involvement, and T2 more useful for evaluating cortical bone and soft tissue extent. CT better for showing area of calcification or ossification. Best technique to identify hemorrhage, edema, inflammation. This is important before biopsy or definitive surgery. Edema usually surrounds malignant lesion and is unusual around benign tumors. This is by MRI. If resection of a tumor is planned, MRI should be performed. So we use it for pre-planning and see the extent of the lesion. Bone isotope scan. Bone isotope scan is the bisphosphonate labeled with technetium-99, usually used in dose of 500 to 600, assess the degree of osteoblastic activity of a lesion. It is an excellent modality to search skip lesion and occult bone involvement. We use it for staging. Sometimes we can find the skip lesion. The lesion is in the proximal part. You can find a lesion in the distal part of the bone. So this we call it as a skip lesion or involvement of another bone. And there's the gallium 67. Lab studies. We can order many lab studies like full blood count. If we want to rule out leukemias or infection, ESR usually elevated. We order them biochemistry, calcium level, phosphorus, liver enzymes, alkaline phosphatase, roll out meds, acid phosphatase, prostate and increased with metastatic deposit, thyroid function test, parathyroid hormone level, PSA, serum protein electrophoresis for multiple myeloma, urine analysis also for multiple myeloma. Now, tumor biopsy. Tumor biopsy, there's a principles for any tumor biopsy. المشكلة إنه we face in the clinic a lot of patients that managed wrongly by taking a tumor. So, should know probable diagnosis and stage of tumor before biopsy, as it is the last step in the staging of the patient. قبل ما فيها يكون عندك differential diagnosis. Performed by surgeon who will perform the definitive surgery أو إنه نفس التيم يعني. So we can take the biopsy, frozen section, definitive surgery during the same anesthesia. This is for the frozen section. Biopsy tract orientation and location is critical. هاي مهم. هسا لازم تختار البيوبسي tract من وين بدك تاخذ البيوبسي and biopsy tract. So we go and do pre-planning by MRI to know where to take the biopsy. So will need to be included in the definitive surgery if the lesion is malignant. So if you have the differential diagnosis and you have the MRI and you do the pre-op planning And if the biopsy is malignant, you can plan for your tract for the biopsy. Of course, you must do a meticulous hemostasis to avoid tracking hematomas and seeding of tumor cells all over with the hematoma. And we send samples for microbiological analysis. يعني مش بس histopathology. So always and always culture your tumor and biopsy your infection. There's a lot of types of biopsy. There's the open biopsy. The open biopsy aim for excisional biopsy when possible, especially in benign lesion. Incisional biopsy preferable in malignant lesion after consultation with the pathologist and radiologist. Always it's a longitudinal incision. Sharp dissection by knife should proceed directly to the tumor. عشان هيك بتعمل بري بلاننج باي ام ار اي مشان تشوف وين اقرب منطقه للتيومر بتقدر تفوت عليها through muscles not through compartment. So the same compartment. Uninvolved anatomical compartment should not be exposed. Avoid all major neurovascular structure to prevent contamination. ناخذ block of reactive tissue pseudo capsule and the block of the tumor. بنحطها بايش؟ فورمالين. بس اذا كانت فروزن سيكشن ما بنحطها بفورمالين، بيروح مباشره للمحتوى. فروزن سيكشن عاده بنستخدمها اذا كنت انت تعمل اكسجينال بايوبسي او ديفينيتيف سيرجري وبدك تتاكد انه this area is clean of tumor ولا لا. Windows in bone should be as small as possible and oval to avoid stress riser and pathological fracture. يعني فتحاتك بالبون لما بدك تاخذ بايوبسي intramedullary if you can do it or as small as possible and oval shape. Release tourniquet prior to closure. مش دائما احنا بنشتغل tourniquet بس بنحط tourniquet. إذا حطيت tourniquet you must release it before closure to do hemostasis. Close with subcutaneous stitches and range should come out through the wound or near to the wound in the same plane. If a proceed following biopsy, new instrument and drabs and to stop seeding of tumor cells. Now, needle biopsy. هسه احنا الفترة هاي يعني صار لنا بحدود كم من سنة عادة شغلنا needle biopsies مش open biopsy. It's as for open biopsy البروتوكول تبعهم. Please the biopsy tract where it can place the biopsy tract where it can be excised. Fine needle relies on cytological interruption FNA يعني. Accuracy is very low 65 حسب الكمية اللي أنت بتقدر تأخذها من tissue sample. Does not allow for immunohistochemical analysis. الكور نيدل بايوبسي عادة احنا هاي ترو كات نيدلز بنستخدم with outer sleeve which close over the true cut, capturing sample of tissue, provide more tissue than fine needle and allows for immune histochemical analysis. Accuracy 75% to 95%. Disadvantage of needle biopsy: tissue obtained may be from necrotic portion of the tumor and therefore not suitable for diagnosis, or tissue may be reactive in nature and not representative of actual tumor, and frozen section may thus be beneficial. يعني this is the disadvantage of needle biopsy. كمية التشيو ممكن ما تطلع كمية كويسة إنه يعطيك diagnosis عليها، أو إنك تكون ماخذ من necrotic tissue أو تعطيك من الرياكتيف zone of the tumor، so ما بقدرش يعطيك diagnosis. عشان هيك بالأوبن biopsy بناخذ زي ما حكينا الرياكتيف zone pseudo capsule and block from the tumor. Surgical margin. We have surgical margins as intralesional margin. It's through the tumor, lead macroscopic tumor, not through. Marginal margin through pseudocapsule of the tumor or reactive zone. وهاي reactive zones فيها inflammatory cells, فيها edema, فيها fibrous tissue, فيها satellite cells. controls non-invasive benign tumor. Recurrence of malignant tumor توصل 50%. Wide surgical margin surround the reactive zone, leaving cuff of normal tissue. Skip lesion left, and recurrence of malignant tumor less than 10%. Radical margin is removal of entire compartment or compartments, distant mid left. And amputation should be thought of as a form of reconstruction where surgical control of the tumor precluded useful function. So this is this is the mass. This is, if you do it, this is intralesional excision. This is marginal margin. This is wide excision with normal cuff, radical all the compartment of, or you can do the amputation. We have a few slides for staging. The staging musculoskeletal neoplasm is INKIN staging system. It depends on the histological grade, site, and metastasis. There's 3 stages: stage 1, 2, and 3. 1 is we have A and B, and 2 we have also A and B, and 3. So 1A, the grade for stage 1, it's low grade, and it's high grade stage 2, and stage 3 could be low or high grade. We differentiate A and B in 1 according to the site, intracompartmental or extracompartmental. Also the 2, stage 2 are the same. Or 1 and 2, there's no metastasis, while in stage 3, if you have metastasis, so this is a stage 3 in despite of the grade. The grading system is G0 histologically benign, well differentiated, and low cell to matrix ratio, while G1 is a low grade malignant, few mitosis, moderate differentiation, and local spread only, have low risk of metastasis. G2 high grade malignancy, frequent mitosis, poorly differentiated, and this is a high risk for metastasis. T0 intracapsular, T1 intracompartmental, and T2 it's a extra compartmental. Metastasis regional or distant mets. So we call it lymph nodes or blood-borne tumors. So take home messages. وأخيرا قررنا نخلص. Orthopedic oncology is a unique subspecialty within the orthopedic and tumor of musculoskeletal system are an extremely heterogeneous group of neoplasm arise from the embryonic mesoderm. No clear risk factor that causes bone cancer. Evaluation of musculoskeletal tumor begins by history, physical examination, and X-rays. Give you an idea of the diagnosis about 80%. The biopsy has principles must be followed, and always culture your tumor and biopsy your infection. Any questions? أسئلة يا شباب. في شباب صاحي معنا؟ ما شاء الله محاضرتك يعني كثير والله. دكتور سيد.
نعم سيدي معك. إذا ما في أسئلة عند الشباب خلص أتوقع سيدي ننتقل للامتحان هسه إن شاء الله.
يعني معقول لهالدرجة المحاضرة واضحة؟
والله سيدي هي واضحة بس يعني بجوز الشباب مش مركز. في محمود عنده سؤال.
والله سيدي يعطيك العافية والله واضحة كثير ممتاز الأمور. شكرا لك.
الله يسعدك يا محمود. يلا خير إن شاء الله بالتوفيق يا رب.
يعطيك العافية سيدي. هلا بك.
الله يعافيك يا رب.